Okay, so without further ado, Dr. Joan Lingen over here is our OB-GYN track chair. She is a graduate of Chicago Medical School, which she attended as an Armed Forces Health Professional Scholar. As a commissioned U.S. Naval Medical Corps officer, she trained at the Naval Hospital in San Diego, California, and completed her internship and residency in obstetrics and gynecology. Her subsequent military assignments include being a staff physician to the U.S. Naval Hospital in Yokosuka. Is that right? Yokosuka. Okay. Japan, and the National Naval Medical Center in Bethesda, Maryland. After working with the Mid-Atlantic Permanente Medical Group Kaiser in suburban D.C. and in private practice occupational medical group in Virginia Beach, Virginia, she is relocated to the Eastern Shore of Virginia in 2005, where she currently serves as the clinical director of Franktown Community Health Center, which is one of 5 federally qualified health centers that make up the Eastern Shore Rural Health System. And I've seen maps of how to get there. It's a very neat place. You get a chance to say hello to Dr. Lingen and, of course, Dr. Piziak, who has chaired this meeting for longer than I've been with SMA. She is Professor Emeritus, Emeritus Director, Division of Endocrinology, and Director of Diabetes Center for Scott and White in Temple, Texas. She has attained the rank of Professor of Medicine and Endocrinology at Texas A&M University College of Medicine and is Professor of Social and Behavioral Health for Texas A&M School of Rural Public Health. Without further ado, I give you Dr. Ronnie Piziak.
This morning we're going to talk about osteoporosis. And I don't mind if you ask questions during the lecture. That's fine with me. So if you have a burning question, you can ask it. Otherwise, you can just write it down on your pad or type it in, and we'll get to it at the end. Unfortunately, I have no relevant financial relationships.
Yeah.
This morning, we're going to take a look at some new guidelines for screening for osteoporosis, some easy, some not. Some new guidelines for therapy from the NOF, and a calcium vitamin D replacement. We're going to look at some new risk factors for osteoporosis that we've seen over the past couple of years, and how are we going to determine the candidates for drug holidays. There's a couple of new pieces of data on that this year, and also there's a new report from the task force on osteonecrosis of the jaw, and there are some new medications that are hopefully coming out. It's supposed to come out this year, hopefully coming out the next first quarter of next year, so we'll take a look at them. I always like to start with the definition of osteoporosis. Remember, this is an osteoclast problem. It's an over-destruction of bone. It's generally speaking not a bone-building problem until you're in your 9th decade of life. So mostly the patients you're going to be looking at are people who are overactive. They have overactive osteoclasts, and because of that, they're destroying bone, and they just aren't keeping up with their bone building. So it's osteoclast-mediated bone resorption, and it leads to holes in the bone and compromised bone strength, which gives us an increase in fractures at all the skeletal sites. But extremely important in osteoporosis is you have a normal mineral to matrix ratio. You're just losing bone. You're losing mineral, you're losing matrix, but it's the total bone, and the ratio is still the same. Now, the medicines we use to take care of that, the bisphosphonates, denosumab, teriparatide, they actually fill in those holes that you're seeing on your screen. They fix the vertical trabeculation, both in the vertebra and, of course, in the hip and throughout your body. So they fix the holes by inhibiting the osteoclasts. Unfortunately, when you inhibit osteoclasts or bone destruction, you also inhibit bone building to an extent. They are coupled, and that's why we're beginning to see people with atraumatic fractures who have been on bisphosphonates and denosumab for a long time. And they inhibit bone destruction 10,000 times more than they inhibit bone building, but eventually that catches up to us and we get a decrease in the turnover of bone. When you decrease bone turnover, you begin to have fragility fractures because you're not remodeling properly. So we're going to talk about that today as well. First of all, let's look at who to screen, how to screen, and to begin with, Who to screen? Well, there are some new guidelines about that, came out end of 2015, and they say that women age 65 or older, as we know, men, the Endocrine Society, I know this is a women's conference, but I just, men are important as well out there, guys. So men age 70 or older, people of whatever gender, if they have significant risk factors, and this year malabsorption has become a significant risk factor. Remember, if your patient has ulcerative colitis, if they've had a gastric bypass or some other malabsorptive surgery, they are going to need to be screened. If they're on steroids, obviously, if they have rheumatoid arthritis. Patients with a fragility fracture after the age of 50. I had a gentleman who was 55, and he came into the office because he had fractured a vertebra picking up a beer keg out of his pickup truck. And so the resident said to me, "You think that's a fragility fracture?" Well, one of my faculty that was sitting there said, "Heck, you can't pick up a beer keg out of a truck in Texas. That's a fragility fracture." So again, it's a fracture you wouldn't expect if you fell from a standing height or picked a beer keg up out of your truck. Okay, so fragility fractures after the age of 50. We already know those people have a problem. Menopausal women with a FRAX score of 9.3, that's equivalent to postmenopausal women who are age 65 on average. And women 65 who've had a fracture, and the NCQA says that, remember, they're the people that make sure we get our money's worth from our insurance company, and they're telling us any woman in your practice, age 65 or more, who has any kind of a fracture, they didn't even say fragility fractures, anything but hands, feet, and skull, you really need to get a DEXA scan, take a look at those people. The other thing that they said this year was, or the end of last year, all women age 70, men age 80, women with a T-score of -1.5, 65 to 69, and so on, those people may need vertebral imaging. And everyone said, "Oh, so expensive, taking those spine films, how many views?" But the key here is if you think someone's at high risk, particularly if they have any back pain, you say, "Oh, hey, all my patients have back pain." No. Anybody at risk who has back pain, anybody who feels at high risk, be sure to get that spine film. You just need a lateral spine film, T3L5. That's one image. It's not that expensive because 2/3 of vertebral fractures are not painful. And we always think of the people we see come in the office with pain, but a lot of pathological vertebral fractures are not painful. So if you have any suspicion the patient has had any vertebral fractures, then be sure that you get the vertebral imaging. How to screen? Well, mostly we're going to screen with a DEXA scan, a dual energy absorptiometry scan. It makes the diagnosis. And please look at the picture. Don't just look at the report, because the report may not be reflective of what's actually there. You also use the DEXA scan to monitor how well you're doing. You have patients on bone-active agents, for example, you have them on bisphosphonates, you say, "Okay, I want to know if they're working." So to monitor effectiveness of therapy, about every 1 to 2 years, you can get your DEXA scan. Medicare will pay every year if the patient's on a bone-active agent. Now, I don't know if you have to hold up your yes or no card. It's early in the morning. But say you have a patient that is on a bisphosphonate. How soon will Medicare pay to have their DEXA? Every year? Yes? No? Yes. Every year. If you want to know things, how many of them have that thing in Epic that pops up when you try to order a DEXA scan every year? Well, it will in about 2 or 3 months. So remember to tell it that they're on a bone-active agent. If you're on a bisphosphonate, if you're on denosumab, if you're on teriparatide, anything over and above calcium and vitamin D, then you will be able to order that DEXA every year to monitor that therapy. Otherwise, if you have them on calcium and vitamin D alone, you're only able to order that DEXA every 2 years. If they have osteopenia, you're only able to order the DEXA every 2 years. Some insurance companies say 5, but you can usually talk them into 2. And again, when you are comparing for efficacy, you want to compare the bone mineral density. You don't want to compare the T-scores. The T-score is a surrogate marker for bone mineral density. So you want to compare the actual grams per square centimeter bone mineral density when you're looking at what happened to Mrs. Schmedlap now and 2 years ago, for example. And finally, the DEXA does predict fracture risk, but only in postmenopausal women not on bone active agents, not very helpful. Use the FRAX. When to retest, again, we said yearly if they're on a bone active agent, probably about every 2 years if they are on just calcium and vitamin D, or they have osteopenia. And in your handout, I've put the only evidence-based study for looking at when to repeat the DEXA scan. So, the main bottom line here is if the T-score is -2 and the FRAX hip calculation is greater than 2, you can tell the insurance company you want to repeat at 1 to 2 years. Otherwise, for osteopenia and people not on therapy, it's every 2 years. Okay, so who to treat? Well, what's our goal here? Our goal is not to increase bone mineral density, because some of the very effective medicines we have, like raloxifene, do not actually increase bone mineral density very much, but they do decrease the risk of fractures. So our goal here is to really get the fracture rate down in our patients. And we can look at who to treat. Remember that most of the fractures occur in patients with osteopenia, although the fracture rate is higher. If you have osteoporosis, you're going to have a higher rate of fractures. If you look at total fractures, more total fractures occur in osteopenic patients. So they walk into your office and you say, okay, I'm going to treat you because you have osteoporosis. How about you? You only have osteopenia. Am I going to treat you? So how do you figure out which of the osteopenic patients you're going to treat? You're going to use FRAX. And now I hesitate to tell you this because everyone then looks at their phone, but there's a free app of FRAX that you can get on your phone, or if you are like me and you have a big computer in your office, then you can just use the FRAX calculator on your computer, and you and the patient can look at their 10-year risk of hip fracture or other types of fracture. Remember, FRAX was designed by Dr. John Canis, and it was a worldwide database algorithm that helps predict the risk of fracture based on your particular risk factors. The most important one is age, after that gender, and again you go on looking at your favorite risk factors. Are you on steroids? Have you had early menopause? Do you use more than 3 ounces of alcohol a day? And so on and so forth. And if you go through that, it will allow you to predict the patient's 10-year risk of fracture. And if their 10-year risk of hip fracture is 3% or more, or their 10-year risk of major osteoporotic fracture is 20% or more, you're going to put them on medication. So you need bone-active medication if they fit into those groups. If they don't fit into that group, then you and the patient can decide. You may still want to do a little something for them. You may want to put them on a bone-active agent. But this helps you decide who has to have it in terms of their risk of fracture. Are there problems with FRAX? Heck, there are problems with every algorithm. It underestimates the risk in early menopause. It's not accurate if the patients have already been on a bone-active agent. So patients already been on alendronate for 5 years, you really can't calculate the risk of fracture. Why not? Because we hope we've changed that risk on the alendronate, right? That's what we used it for, was to decrease the risk of fracture. So their risk factors are not the most important thing anymore. It's the bone-active agent that's going to determine their risk of fractures. Okay, so if we look at the World Health Organization diagnostic categories for osteoporosis, remember a T-score of down to -1 is normal, -1 to -2.5 is osteopenia, and -2.5 and below is osteoporosis. But remember also that the DEXA scan doesn't measure bone strength. So it underestimates the risk in people who have bone matrix disorders, and that's diabetes and sleep apnea. The last couple of years, we've noticed that people with particularly type 2 diabetes have a much higher risk of fracture than we would estimate from their DEXA T-score. Also remember that it doesn't distinguish between diseases. It doesn't tell you if the patient has osteomalacia, vitamin D deficiency. Remember that osteoporosis is normal mineral to matrix ratio, and in osteomalacia, which is vitamin D deficiency, we have poor mineralization. But the DEXA doesn't tell us that. It just tells us how much calcium is there. It doesn't tell us how much of the matrix is there. So it doesn't tell us what kind of a disease the person has. They may have Paget's disease of the bone, and we got into a Pagetic area in the femur, and it has a low bone mineral density. So again, doesn't tell us diseases, doesn't tell us bone strength, but overall does a pretty good job of telling us who's in trouble, who's at risk, and who we should treat. Let's take a look at the problem with bones and diabetes. It's really kind of interesting. It turns out that when you glycosylate things, remember glycosylated hemoglobin that we're going to talk about as we go along in this conference? Well, you glycosylate a lot of things. If you have extra glucose in your bloodstream, you stick them on your basement membranes of the kidney, giving you nephropathy. You stick them on your retina, giving you retinopathy. You also stick them on your bones, giving you poor bone structure, so that the bone, the matrix isn't good. And so as you mineralize it, you don't do as well, and the bone isn't as strong. It's easier to dent. This is a terrible experiment that no one's going to sign up for, but what they do is they take your radius and they press on it until it dents, giving you a big bruise, but it dents more easily in people with diabetes. They must have paid a heck of a lot to tell people to come and do that experiment. But it's mainly in type 2, which is an inflammatory disorder, and it raises the risk of hip fracture in young people with type 2 diabetes 6-fold over their compatriots that do not have diabetes. So what is the bottom line here? Well, don't wait for the T-score to be -2.5 in your patients with diabetes before you treat them with a bone-active agent. You have to treat these people a bit early. We don't know the exact coefficient yet, but it would appear a T-score of -2.2 to 2.3 in people with diabetes is where you may want to start a bone-active agent, because they're going to fracture at a higher T-score than most of your patients. So don't wait for -2.5 before you treat the folks with diabetes. So how about obstructive sleep apnea? Anybody have people with obstructive sleep apnea in their practice? Okay, see some nodding over there from one of the speakers. Thank you, I'll pay you later. Okay. Well, people with sleep apnea have almost 3 times the chance of developing osteoporosis, because hypoxia stimulates osteoclasts. So while you're not sleeping and not using your CPAP, then your osteoclasts are working. So you need to help those people get at least 7 hours sleep using their CPAP. And the other thing you need to do is they frequently have vitamin D deficiency. So add them to your list of people to screen for vitamin D deficiency. Measure the 25-hydroxyvitamin D in those folks. And if they're men, then you're going to use bisphosphonate, not testosterone, to treat their bone deficiencies. Okay, who are we going to treat? Well, the NOF says anybody who has a fracture, they're greater than age 50 and have a hip or vertebral fracture, those people have osteoporosis. I don't care if they fell off the roof, if they're over age 50 and they got a hip or vertebral fracture, no, just kidding. They can fall off the roof, they can fall off their motorcycle, but if they had a fall from a standing height, or remember the beer keg guy, then you need to treat those people. Other prior fracture and low bone mass, T-score of -2.5 we already knew. But remember, the people on steroids, low bone mass and secondary causes, if your patient has a T-score of less than -1, that's less than normal, and they are on steroids, they ought to be on a bone-active agent. So really need to take a look at those people you're going to put on steroids. The Rheumatologic Society that creates the rules for steroids says, hey, if you're going to put them on steroids for more than 3 months, you ought to put them on a bone-active agent to prevent them from losing spinal bone mineral density because they may not reaccrue it. And of course, we looked at the FRACs. And so Medicare will pay for bone-active therapy in patients with a 10-year hip fracture probability of greater than or equal to 3%, as we said, or a 10-year major osteoporosis-related fracture probability of greater than 20%. Okay, how to treat? Well, gosh, you know, everyone's worried now. I say, Mrs. Schmedlap, are you taking your calcium? And she says, I'm afraid it's going to clog up my coronary arteries. She says that, of course, as I look in her purse and see the McDonald's wrapper around her, stuffed in there so that she's just had her greasy burger. But remember, it's not going to do this. We looked at WHI, 1,000 milligrams of calcium, 7-year follow-up, no cardiovascular disease events in the treated group more than in the group that was not taking the excess calcium. Again, Nurses' Health Study, no association. The biggest study looking at calcium and coronary artery disease and cardiovascular death is the National Institutes of Health Diet Study, still going on, looking at self-reported calcium intake over 1,000 milligrams a day. And they said there's no association if you take 1,000 to 1,200 milligrams a day with cardiovascular disease in women. This is well over 100,000 people. They've been followed for almost 12 years. And hopefully, the end of the story, the Bone and Mineral Society employed Lewis and his colleagues to look at every single qualifying study between 1966 and 2013. It took them 3.5 years and a lot of coffee to keep awake. But at any rate, there's no increase in cardiovascular mortality on 1,000 to 1,200 milligrams of calcium supplement. Okay? There's never been an association with dietary calcium and cardiovascular events in any study. So where should your patient get their calcium? Their diet, if humanly possible. How much? Well, the National Academy of Sciences says, again, men and women greater than age 50, 1,200 milligrams a day if they have normal renal function. Remember, if your patient doesn't have normal renal function, say they have stage 3 renal disease, estimated glomerular filtration rate less than 60, those people do not do well with 1,200 milligrams of calcium. They can't clear it, so they're liable to get hypercalcemia. So if your patient has stage 3 renal disease, talk to their nephrologist and sort of work out something with them. Most of our patients take about maybe 600 to 800 milligrams of elemental calcium when they have stage 3 renal disease or higher, stage 4. Remember that the U.S. Preventive Health Task Force told us way back in 2013 that we shouldn't use supplements for primary prevention in healthy postmenopausal people. Okay, is someone with osteoporosis a healthy postmenopausal person? I don't see any cards there. No. So I told Randy that people aren't good at this hour in the morning at getting those cards up. So I'll answer my own questions. No. So osteopenia, osteoporosis, those people may need calcium supplements. But again, dietary calcium is best. Your normal postmenopausal woman does not need to chunk down 1,200 milligrams of calcium supplement. She should be getting some dietary calcium. How about vitamin D? The National Academy of Sciences says 600 to 800 IUs a day, but they also say more than 4,000 a day is not a good plan. And I have to tell you that I see a lot of people taking more than 4,000 IUs of vitamin D a day. You know, they come into your office and they have this giant sack of supplements. Oh, I just look at that. I have a 20-minute visit here for follow-up, folks, and I'm looking at that. I'm thinking, in 20 minutes, I can't even find the bottom of that sack. So you know, just toady up as well as you can, but we don't want lots of extra D. Gives you hypercalcemia. D is difficult to obtain from dietary sources, and so you probably are going to have to supplement. Now, what about D deficiency? It leads to osteomalacia, increased fractures, increased parathyroid hormone. You definitely don't want that because that chews away at your hip to remove bone to preserve the calcium in your bloodstream. So again, we don't want D deficiency. And I see people coming in with vitamin D levels of 10, and folks have them all kinds of stuff. All you need to cure vitamin D deficiency is vitamin D, right? You don't need 15 extra things like strontium. Okay, so what is vitamin D deficiency anyway? We're going to treat deficiency. We know that calcium absorption decreases in D deficiency. That is, generally speaking, less than a 25-hydroxy-D of 20. And 25-hydroxy-D is generally reported now in the United States in nanograms per milliliter. Then we had something called vitamin D insufficiency. That was between 20 and 30, 25-hydroxy-D between 20 and 30, and then normals 30 to 60. Well, recently, the clinical endocrinology metabolism people put out a series of guidelines that got rid of insufficiency. So if you're treating people whose 25D is between 20 and 30, you really don't have to do that anymore. You want to treat deficiency, so you're less than 20. But if you're, if you're between 20 and 30 and you don't have osteoporosis, we can leave you alone. So all those people that come to your office and have a 25-hydroxy-D of 25, you can leave them alone. If they have osteoporosis, you may want to inch them up to the 30 range. But basically, healthy people down to a 20 are A-OK, because only about 3% of them will have that elevated parathyroid hormone have any problem with their bones, and they generally already have osteopenia. So again, healthy person, normal bones, don't bother to treat between 20 and 30. Just treat the people who have a 25D of less than 20. So there's what the U.S. Preventive Health Task Force thinks is ideal, and the Endocrine Society, for once, agrees with them. Okay, who are we going to screen for D deficiency? Well, you can read this list as well as I can, but young patients with a fracture at any site or a low bone mineral density, and that what's young? It changes as you get older, but I have to tell you, age 50 is okay. Young is less than 50. So in the when they looked at the Bone and Mineral Society guidelines, young patients would be people less than 50 with a low bone mineral density. Obese people frequently have decreased production of 25D. You may want to screen them, particularly if they're going to surgery. We see a lot of people going to bariatric surgery and they have increased parathyroid hormone and decreased vitamin D. May want to get some of those people on vitamin D before they go. Anybody with rapid turnover disease, hyperthyroidism, Paget's disease, where they have to make bone well fast, going to have to screen them. If they're D deficient, they don't make bone. And remember the folks with the gastric bypass. We said they're malabsorption, and this year the Bone and Mineral Society has a big push on to screen those people for D deficiency. About 95% of the people you see in your office who've had a gastric bypass have D deficiency. They're not like 25, they're 10 or 4. I saw a lady the other day whose vitamin D level was below the assay limit. So got to really fix those people. How are you going to fix them? Well, same way, nothing has changed this year. 1,000 international units a day. If they're just minimally D deficient, we'll do it. For significant deficiency, it's that same old 50,000 international units once a week for about 8 to 12 weeks. And remember, if they're large people, if they're over 200 pounds, 50,000 is not much higher than their usual requirement. D is a fat-soluble vitamin, and in order to be between 20 and 30 25D levels, you need about 50 international units of D per kilogram per day. If your patient weighs 400 pounds, as my patient did the other day, 50,000 a week is like a spit in the ocean. So remember, higher weight, higher D supplementation, please. Okay, so as we finish here, we're going to talk about how to treat. One thing about having a really good AV guy is as soon as I talk too loudly, he runs in and fixes it. Okay, we're going to use approved medications. And if you have questions about raloxifene or vasodoxifene, I'll answer those, but I think we're not going to spend much time on them. Calcitonin. Oh, the only thing we want to say about calcitonin is there's an FDA warning for increased malignancy in people using that. And the FDA says if you're going to prescribe calcitonin for someone, you must discuss with them that there is an increase in liver cancer in patients who use this. It also doesn't decrease the risk of hip fracture. So I can see myself writing that prescription. Here you go, Mrs. Jones, and this increases your risk of cancer, but really won't do much for your bones. So if I were you, I would take calcitonin out of my armamentarium to sort of scratch it right off my list. So we're going to spend most of our time on bisphosphonates, teriparatide, and denosumab. So here, malignancy risk. I want to point that out to you. It has to be discussed with your patients before starting calcitonin. And the other thing they're saying is if you have them on it, every year you want to see if it's doing any good. Because if it isn't, you need to get rid of it. Okay, how about alendronate? Everybody using alendronate? Everybody out here? Is there anybody who isn't? I shouldn't say that. Randy would. Is there anybody who needs to hold up their no card? I'm trying. It isn't working terribly well. Nobody's doing it. If you don't do this, Randy's going to be really annoyed with you. Okay, sorry. So alendronate is still the most commonly prescribed bisphosphonate. It is approved for everything. Prevention and therapy of male osteoporosis, postmenopausal osteoporosis, steroid-induced osteoporosis, and it works. It decreases the risk of hip fracture by about 50% at 5 years and decreases the risk of spinal fracture by about 80%. So again, very effective. But the key here is how long to use it. And the FDA helped us out in 2014 by saying, we don't know, but you ought to look around every 3 to 5 years when you have people on this and see if they still need it. So again, very effective. Long half-life in bones, though, at least 5 years of a half-life in bones. Risedronate, marketed as Actonel, and abandronate, which is now generic, are less. You can use them once a month instead of once a week. The bone turnover in risedronate, or Actonel, is back to normal in about a year. Has a very short half-life in bone compared to the other bisphosphonates. Abandronate has really no advantages over alendronate or risedronate, but you can use it if you want. It's now cheap, and it's once a month. How many of you use zoledronic acid, or used to be called reclast, in your practice? A yes card. There we go. 3 of those people. So not many of you use zoledronic acid. It's the most potent of the bisphosphonates that we have. It lasts in the bone for about 3 to 5 years, and it's a 15-minute infusion. You need to make sure that when anyone is on a bisphosphonate in your office, you've looked at their estimated glomerular filtration rate. It comes now with the lab. If you're over age 60, it's printed right in there. And you want them to have an estimated glomerular filtration rate of about 40. You don't want to use bisphosphonates with an estimated glomerular filtration rate of less than 40, because then their clearance isn't good and they can create problems with the kidneys. So you don't want them hanging around in the kidneys. You also want to make sure that your patient does not have hypocalcemia before you give these, because they can have seizures. Remember that all bisphosphonates lower the calcium in the bloodstream when you give them, and seizures are just so tacky in your office. So remember to avoid those. In addition to that, you may want to consider getting a vitamin D level before you treat things, before you treat people with bisphosphonates, because we know that people with low 25D levels, that's not 22, that's like 15, 10, 3, real vitamin D deficiency, are much more likely to get terrible bone pain when you treat them with bisphosphonates. And when that happens to them, they get very annoyed, and you end up putting them on a morphine drip in the hospital. So if you want to avoid bone pain, be sure that D is pretty close to normal when you treat people, particularly with potent bisphosphonates like zoledronic acid. The interesting thing about zoledronic acid, even if you don't use it in your practice, is that it was the last one to come out. So the FDA said, hey guys, we know that maybe we shut off bone building when we use these bisphosphonate things. So we want you to tell us, how likely are we to shut off bone building on your drug? And so they did this. And at 36 months, that's 3 years on this very potent bisphosphonate, the patients all had a decrease in bone building. We used to think that atraumatic fractures just occurred in really incredibly unlucky people who became suppressed. But it turns out that every single person you put on a bisphosphonate begins to have a decreased bone building rate by about 3 years. Now, how much it decreases depends upon the person. That's pretty individual. We don't exactly know who's at high risk, but we do know that that's what happens. So we know that everybody's getting a decreased bone building rate. We just don't know how much. How about denosumab or Prolia? I bet a bunch of you use that. Yeah, okay. It is really good. It's easy to use, but the indication is postmenopausal osteoporosis with a high risk of fracture. And you say, why? How come with a high risk of fracture? Because it has more side effects than the bisphosphonates. It's also contraindicated in hypocalcemia, pregnancy, and allergy. But the side effects are significant. So before you use denosumab or Prolia in people, you need to ask them, do they have skin disorders? Because it is a problem. The rank ligand, which is the little protein that causes bone destruction, it tells the osteoclast, get moving, get healthy, work better, live longer. And so what we do, we want the osteoclast to live shorter and work less well, is we take away their rank ligand. Rank ligand also forms part of the barrier function of the skin, the bronchus, the urinary tract. And so if you have a patient that has psoriasis, for example, and you give them denosumab, they will have a big flare. If you have someone that has a lot of UTIs or a lot of bronchitis, they may have a problem. So be sure you ask about significant infections, particularly urinary tract, skin, and bronchus before you use this. If the patient has those, you don't want to use it. So psoriasis, atopic eczema, or other chronic skin conditions, it is contraindicated. Okay, you can also have osteonecrosis of the jaw and atraumatic fractures, but they're much less likely than they are on long-term bisphosphonate. And this year, the FDA said we had to warn people you can have severe muscle and bone pain too, but remember again, get that 25-hydroxy-D, and that's going to help you out. This denosumab can be used in patients with renal disease, and we use it frequently in those patients. And when you do, you need to check the 125-dihydroxy-D to check whether or not they have a D deficiency. Remember, in renal failure, you don't make the 125-D. So you're going to check that in those patients. Okay, how about osteonecrosis of the jaw? Well, there's a new international consensus about that. And look at how common it is. Oh my. In your general population and the patients you treat with osteoporosis with the usual osteoporosis doses of bisphosphonates, there's no difference. So again, your patient says, oh, I'm afraid I'm going to get osteonecrosis of the jaw. Well, you're about as likely to get it just standing there doing nothing as you are when I give you bisphosphonate. So, you don't have to worry about that. The people who get osteonecrosis of the jaw are people who are on high doses of bisphosphonates for cancer, high doses of denosumab for cancer therapy. They're also the people who have poor oral hygiene. So the big recommendation was that you ought to look in their mouth. And if you see something like this when you look in their mouth, don't give them a bisphosphonate. Actually, send them to the dentist. And the dentist does a Panorex. You can actually see, I have to find my pointer here. Here we go, the pointer. But you can actually, well, you can't see. There we go. You can actually see, you see the teeth. Look at the hole in the jaw. I mean, this is where that is. It's a hole in the jaw. And you can see it here. But again, just looking in the mouth, sometimes it's a little difficult to see. You see it's coming up here. But if you can look down and see the bone right there, if you look at somebody's mouth and you see a bone sticking up that isn't a tooth, right away, you want to send them over to the dentist, okay? Prevention. This whole committee was paid a large amount of money to review the literature, and they said good oral hygiene. So brush your teeth. Correct dental disease before starting anti-resorptive agents. And in the patients at high risk, you can stop the anti-resorptive agents following extensive dental surgery and resume when the site is healed. Does it help to stop alendronate 6 weeks before? It's in the bone for 7 years. Probably isn't going to help you to stop it 6 weeks before the procedure. So what they said is stop it after the procedure, look and see if the bone's healed. So when the dentist calls you now, you know what to say, right? Okay. Okay, let's take a look at atraumatic subtrochanteric fractures. So how long are we going to treat with a bisphosphonate? Well, they're really a hard act to follow. We said 50% decrease in hip fractures, more than 90% of people respond to them. The risk for a hip fracture is 750 to 830 per 100,000. That's how many people have hip fractures. We can decrease that by 50% with bisphosphonate. Don't be afraid to use them. And I find people sending me emails as they do. We have a system that's enormous, has about 1,300 doctors, and presently we have 4 endocrinologists, and one of them's out on pregnancy leave. So let me tell you that we have a lot of emails every day, and people say to me, do you think I should use a bisphosphonate when Mrs. Smith has fractured her hip? Yes. 50% decrease. What's her chances of getting osteonecrosis of the jaw? 0.001%. Okay, so 80% decrease, we said, in fractures, effective in 6 to 9 months. In 6 months, you decrease the risk of vertebral fractures. In 9 months, you decrease the risk of hip fracture. And they're safe, according to the FDA, for 5 years of use in the vast majority of your patients. Now, what's the risk of atypical fractures? We don't know, but there's only been one study, and this was not a prospective randomized controlled study. This was a look back in the Kaiser Permanente system. And after 5 years, there are about 16 atraumatic fractures per 100,000. By 9 years, there were 113 per 100,000. So remember, look, 750,000, and we can reduce that by 50%, and we're going to have a few people who are going to have atraumatic fractures. So again, don't hesitate to use bisphosphonates. You just have to learn how to use them for a shorter period of time. That references Dell. It's the only, and they did a new look back this year, early this year, and this is the only decent study to date. Okay, so when can we tell if people are at risk? That's the really hard part. Well, 70% of people who have this problem with oversuppression of bone are going to have dull, achy pain in the groin or thigh. And you say, oh, heck sakes, everybody I own has arthritis of the hip. No. They're going to have it's thigh pain. It's like femoral pain. It's all the way up and down. It's like a toothache. It's like a stress fracture, because that's what these are. They're stress fractures. And there are people who are at risk, people with comorbid conditions, D deficiency, as we just talked about, rheumatoid arthritis, diabetes, and people who use bisphosphonates or steroids also are at higher risk. With or without bisphosphonates, your steroid-treated patients are at higher risk of subtrochanteric fractures. So, what are they? They are stress fractures. And when you get that pain symptom and you say, gosh, I wonder, don't wonder. Just send them for an x-ray, because the radiologist can tell, even the endocrinologist, right there, look at that. I mean, is that normal? Certainly not. Does it look like that side? That's how the endocrinologist reads x-rays. Okay, does that side look like that side? Certainly not. Okay, there's a bad problem there on one side or the other. And so, again, you're looking at the beginning of a stress fracture. If you don't do anything about it, it breaks right along that stress fracture line. So if those people have pain, don't worry about it. Just send them right off to the radiology department for an x-ray. And don't second guess yourself and say, oh, I don't know if the insurance company will pay. Believe me, if you write high risk subtrochanteric fracture or atraumatic fracture on your x-ray ticket or type it in, they'll pay. Okay, so when do we get a drug holiday for people? We don't know. But anyway, I'm going to give you the two sets of data because we don't know. But two sets of data. The FDA went over all the data for alendronate. So it used to be called Fosamax. All the data. And Merck gave them everything they had. And they said in women with no prevalent fractures, they haven't had any fractures, and you've got them on a bisphosphonate. If they have osteoporosis, keep on, because the risk of fracture far outweighs the risk of the subtrochanteric atraumatic fracture. So the risk of traumatic fracture far outweighs your risk of atraumatic fracture if they still have osteoporosis. But it said, heck, if they don't have osteoporosis, the T-scores above -2.5, like -2, -1.8, you can stop. Okay. How about the people with prevalent fractures? You already had a fracture when I put you on the bisphosphonate. You've gotten a fracture while you've been on it. Remember, only prevents 50% of fractures. Then if you're osteoporotic still, yeah, sure. But if you're -2 to -2.5 T-score, keep right on, because the risk of fracture far outweighs the risk of bone suppression in those people. If your T-score is above 2, you can stop. So that's a handle you can put on it. Applies only to alendronate. The others, remember, have a shorter half-life in bone, so certainly probably applies to them as well. How about zoledronic acid? This is the only other set of data we have, and they said if you haven't had a fracture at baseline, you're not osteoporotic anymore, and you haven't had any fractures during the study, obviously you can stop those people. And you can stop them for 3 years. Zoledronic acid is very potent. So usually they're pretty stable for 3 years. Even if they have osteoporosis, if they haven't had any fractures and they've been on it 3 years, you can stop it. And if they don't have osteoporosis, but they've had a prevalent fracture, you can still stop it if they haven't had any fractures during the 3 years you had them on the zoledronic acid. So again, this is very potent. It works, and I've had people now off zoledronic acid for 3 years. Rock solid, stable bone mineral density. Okay, so this is the latest. This was published in January of 2016. These people went through the entire literature we have on atraumatic fractures, which was so short because there isn't much. And they said if your patient hasn't had a fragility fracture ever, and their T-scores -2.5, keep them going. Continue for up to 10 years. We think it'll be okay. Just keep looking every 2 or 3 years, and if they're out of the osteoporosis zone, then stop the bisphosphonate. So how about if they have had a fragility fracture? They said, we don't know. We have no data. Continue for up to 10 years or consider alternative therapy. And keep looking every 2 or 3 years, but we don't know what that'll get you. I mean, I'm sorry, but that's what there is. They said, what about the people on steroids? They said, oh, your patients on steroids continue if they have a T-score of -2.5, or continue as long as their T-score is -1 or lower. So if your patient's been on steroids, you just got to do it. When is the holiday over? Well, you can obtain DEXA scans yearly. You can convince the insurance company. If they won't, every 2 years is probably okay. And you look for a significant decrease in bone mineral density. That's really the only way you can tell. You can look at bone markers, but they're not quite as good because they're not paid for by the insurance company and they're very expensive. So what's the alternative therapy as we round up? Well, there's only one. If you're on anti-resorptive agents, which would be bisphosphonates or the denosumab, then teriparatide, marketed as Forteo, is presently the only anabolic agent approved for osteoporosis, and it stimulates osteoblasts. So if you want to change your patient from a bisphosphonate, or if they have severe osteoporosis, you can use teriparatide. When do you use it? T-score of -3 with previous fractures. You can start out with it. Fractures on a bisphosphonate, or if they are unresponsive to bisphosphonate, or, as we just talked about, on bisphosphonates too long. And it has very few side effects, but it's extremely expensive. Does anyone use Forteo out there? Teriparatide? Yeah, a bunch of you do. Okay. Well, very good addition to your armamentarium, easy for the patient to use. Now, I wanted to talk for the last few minutes, and I'm running ahead. Randy, I can't believe that. Yes? Oh, I don't know. Anyway, there are two new things that are coming out. The cathepsin K inhibitors. Cathepsin K is the primary osteoclast protease, so it destroys the matrix. So this is one of the very important things that cause osteoporosis. And there are inhibitors of that, and they're enzyme inhibitors. So they reduce bone resorption, but they do not decrease bone building. And so that's one of the great things. We're not going to have to worry about drug holidays and all kinds of problems with atraumatic fractures, because these don't reduce bone formation. They preserve bone formation. It's an enzyme inhibitor. So you throw it in there, it inhibits the enzyme, you stop destroying bone, you take it out. When does the enzyme start out again? Same minute you take it out. So you stop the medicine, the bone begins to be turned over again. Now that's a plus and a minus. It's great because you're not going to have atraumatic fractures, but your patient misses 2 or 3 of these pills that are once a week, and what's happening to them? They're getting bone destruction again. So I think we can all counsel them that they got to take their pills, but this is going to be just a really great addition. The other addition, I don't know if I put in, this is the one that's a front runner. There are lots of these. There are lots of cathepsin K inhibitors. The one that's a front runner is Zoledronic. And look at this. More than 16,000 patients, 34 months follow-up, 50% reduction in hip fractures, roughly vertebral fractures, 72%. So it's about the same as the anti-resorptive agents that are presently on the market. Non-vertebral fractures, 23%. That's about equivalent to what we have on the market now, but it's oral, it's once a week. So really great. And the other one, I don't know if I put in. No. Okay. The other one is going to be anti-sclerostin antibody. And I told you, ladies, we are really in a hole here. At menopause, you know what happens? The precursors of our bone-building cells, they're sitting around in the bone marrow waiting for stuff to happen, deciding what to do when they grow up. And they have a choice. They can become osteoblasts, which build bone, or adipocytes, which build fat cells. Oh, shucks, Well, so what happens to us at menopause? They go down the adipocyte pathway. It's really bad. Men don't have that problem. But at any rate, they do lose bone, though, guys. So what happens is that sclerostin causes them to go down the adipocyte pathway. And so now we have a sclerostin antibody that shuts that off, so we go down the osteoblast pathway. Whoa, yes. So that's really good. And it should come out, it's supposed to come out last year. It should come out about the first to second quarter of the coming year. And it increases bone mineral density by about 10% over the course of a year. It's really an amazing pharmaceutical. So we'll be getting to that. And last, I wanted to give you this one case because you can save this lady's life, particularly those people who treat adolescents. How many of you treat adolescents here? Okay. They're better with hands than they are with the old yes cards. All right. There's a 16-year-old lady, and she had an atraumatic left femoral fracture. How many 16-year-olds just step off the curb and fracture their femur? None, okay? 6 months ago, and it had delayed healing. So early fracture, delayed healing. She says, I have lots of fractures. In addition to that, she's had all kinds of surgery for fractures. She has chronic bone pain. She doesn't heal. She's lost all her teeth. She's had renal stones. She also has seizures. So multiple fractures, seizures. Don't use a bisphosphonate in this lady. They don't work. But before that, get some lab. And you say, what lab? Anytime a young person comes into your office, young, that's less than age 50, okay, comes into your office and has had fractures, you're going to get the same lab. This gets you about 90% of the weird bone diseases that cause young people to have fractures. So again, you want a calcium, you want a phosphorus, you want a PTH. They can have a calcium leak. Interestingly, one of the main causes of fractures in young people is a calcium leak from the kidney. It's really unusual. They can have a phosphorus leak from the kidney. They can have hyperparathyroidism or low vitamin D and kidney problems. And those are about the whole list, except this one at the bottom, alkaline phosphatase. And if you get those, you're going to catch this lady. Her alkaline phosphatase will be really low because she has hypophosphatasia. You say, oh, heck, I've never heard of that. Well, and I hope you don't ever hear that, but please, young person, early fractures, non-healing seizures. You just remember those things, and you get an alkaline phosphatase, you can save this lady's life because she's missing alkaline phosphatase, and we now have it. It was an orphan drug just put out by the FDA, and it's tissue nonspecific alkaline phosphatase. And if she injects that 3 to 6 times a week, she takes care of all her problems, and you saved her life. So don't miss this lady. Or the other, young people. Remember, young people, that's the lab. Too young to fracture, is fracturing, get this lab, you'll figure out what's wrong with them, and frequently you can save a life doing that.